Good afternoon, everyone. Thank you for joining us for our webinar today. I'm Melinda Bikini, Director of Advocacy with the Cholangiocarcinoma Foundation, and we're also joined by Isabel Gardette. She's our Director of Industry Engagement. And today we're going to be talking about the release trial and the technology behind. We have with us Lena Finisand from PCI Biotech, and also, see, I've already messed it up, Jorg Trojan, who will be doing the presenting. So, and Amir is also here from PCI Biotech. So I just want to let everyone know that we will have time for Q&A at the end of the webinar. So please put your questions into the chat box or the Q&A box at the bottom of the page, and we will get your questions submitted and answered. And so I'm going to go ahead and turn it over to Lena. Thank you for joining us.
Yes. So welcome everybody. So this webinar is intended for patients with inoperable extrahepatic, which means perihilar or distal cholangiocarcinoma, and who consider enrollment into a clinical trial. I believe we have some patients in the webinar, but we also have caregivers and other researchers. And I believe and hope that you will find this webinar and interested for you as well. So in our study, the release trial, all the patients will have the standard treatment of gemcitabine and cisplatin, and half of the patients will receive the experimental PCI treatment in addition. So PCI treatment is the experimental treatment and sponsored by PCI Biotech. So by that, I will hand over to our expert here today. And that's Professor Jorg Trojan. You can introduce yourself by the next slide, please.
Hello, everybody. My name is Jorg Trojan. I'm a gastroenterologist and oncologist working at the University Hospital and Cancer Center in Frankfurt. I'm running a lot of clinical trials in our unit, and I have a long history actually of treating patients with hepatobiliary tumors and especially cholangiocarcinoma and of course hepatocellular carcinoma. On my next slide, I will give you an overview what is actually the goal of this webinar. Lena already introduced something about the trial, the release trial. It's for patients with cholangiocarcinoma, and I will further define actually which patients are able to be included in this trial and what the goal of this trial is. I will also guide you through the technology we are using. It's actually not a photodynamic treatment. It's more than a photodynamic treatment. It's a combination of photodynamic treatment and a special technology. And of course, I will also comment on the typical of this trial, what is needed actually, and what are the major goals, and also about some practical things of the trial and potential risks. On the next slide, please. On the next slide, I will show you what we are actually seeking for. It's a trial for patients with hilary tumors and extrahepatic tumors. So hilary means either in the hilum or a little bit above. And of course, what is really one goal is that the patient have a stenosis which needs stent placement. The standard of care actually in those patients is stenting for biliary drainage and systemic treatment with cisplatin and gemcitabine. And this is our standard treatment arm. So we are using a standard treatment, and in the experimental arm, we are using additional this treatment called photochemical internalization, to which I will come a little bit later. Of course, the patients should not have been treated for their cholangiocarcinoma, but if you have started chemotherapy, you might still be eligible. So 2 cycles are allowed. There's a protocol amendment going on, and this can be checked at the sites who are participating. On my next slide, you see the design of the trial. The design of the trial actually is that we have a randomization, a one-to-one randomization of patients with inoperable perihilar or distal cholangiocarcinoma, and are randomized to each of those arms I explained already. If the patient is going to the experimental arm, we start with the photochemical internalization procedure, which is actually a kind of ERCP procedure, and I will show you a little bit later. And then the patient gets treatment with chemotherapy, with gemcitabine and cisplatin. In the Amphinex, that's the name of the drug used for photochemical internalization. Amphinex is being injected 4 days before the procedure. 3 ± 1 hours before the procedure, gemcitabine is then infused, and thereafter there's the endoscopic procedure. Remember, all patients must have a stent, and at this procedure then we need to get access to the bile duct, to the tumor stenosis. Next slide. This is the technology behind. It's called PCI, photochemical internalization, and actually it's just hit forward. Just move forward the slide a little bit. Yeah, it's actually the principle behind is the substance, the Amphinex, helps to move the cytotoxic drug gemcitabine by endocytosis into the tumor cell, and the procedure of the photodynamic treatment makes the cell membrane, the cancer cell membrane, more leakage. So the principle is that gemcitabine is being transported into the cancer cell and can there destroy the cancer cell. Move on with the slides, please. So this is triggered by the laser. With the laser, we activate actually the substance, and then move on, please. With the slide, it's being released in the tumor cell. Next slide, please. Just move forward. Can you move forward? Yes, wonderful. So the goal of this treatment, of the photodynamic plus photochemical internalization procedure, is to shrink the tumor by increasing the effect of gemcitabine. And in this study, we want to evaluate the effect of this procedure in addition to the standard of care, which is stenting together with systemic chemotherapy with gemcitabine and cisplatin. And if you move forward, you can see the study site. So we have a lot of study sites in Europe which have been activated already, and also in the Far East, in South Korea and Taiwan. And in the US, we have six very experienced with endoscopic procedures, and also, of course, with systemic treatment procedures, centers, which you can see on the map in the middle. And these 6 sites will be open or will reopen pretty soon to have access to this technology. You can move forward, please. This is just to give you an idea where the study is being placed in Europe. Move on, please. And in the US, we come to the name of the sites later in the presentation. Just move on, please. And again, further. So what is our experience? And I was part of the phase 1 study in cholangiocarcinoma. And we treated in the phase 1 study. The results have been released in part in international meetings. It's not fully published yet. We have treated in the phase 1 study 23 patients. What we have seen is that almost all patients got some temporarily sensitivity to light, which is always the case with a photodynamic treatment. And what is important, there were signs quite impressive of tumor shrinkage. And also we have seen a very, very promising progression-free survival. That means without any treatment, also after the end of the study, and also some very encouraging overall survival data. Move on, please. So this is now the treatment. Remember, all patients must have a stenosis which requires stenting for biliary drainage. It's a laser treatment. So when the substance have been injected, 4 days later, then the patient comes to the endoscopy room with, of course, light protection. And we are doing a normal ERCP procedure. First, we remove the stent, and then we place a standard ERCP catheter in the bile duct through the stenosis. Thereafter, we place a cylindrical light diffuser, which you can see here on this slide. And then the laser is being activated, and that's the principle. With a specific light, we activate the substance, the amphinex, and then on the far right of the picture, you see the very nice bile duct, and you see the catheter and the light diffuser in place inside the stenosis. And that's the principle, that we activate there the light to destroy the tumor cells and to make the tumor cells more leaky towards gemcitabine. Next slide. This is a fluoroscopic picture of a patient we have treated in the phase 1 study. This was a patient from our center. On the left, you see the stenosis. The dark thing, that's the endoscope, and you see the tumor stenosis with the white arrow marking the tumor stenosis. On the second fluoroscopic picture, you see the guide wire and the laser cable and actually the catheter in the tumor stenosis. And on the right, you see the results after 10 weeks after the procedure. So the stenosis pretty much resolved in this patient, and this patient had a quite nice and long progression-free survival without any treatment. Move on, please. So that's me in the procedure room. So it's a typical ERCP procedure, and the endoscopist must be experienced for sure. And also, actually, the team must be experienced in side effect management and, of course, also in the systemic treatment of those patients. Move on, please. So what is necessary during this trial? Of course, a patient must come to the hospital a little bit more often, actually, than outside a clinical trial. This is always the case. But just during the first 6 to 8 months. Thereafter, it's a kind of routine follow-up every 3 months for imaging, actually. What we are doing, what we are always doing in a clinical trial, but also in clinical routine, patients get standard examination with standard imaging. And the chemotherapy is also standard of care. It's a typical gemcitabine and cisplatin regimen, day 1 and day 8. We in Germany and many other countries apply this chemotherapy on an outpatient basis. In some hospitals, it could also be applied as an inpatient basis. And then it's repeated after 21 days. Up to 8 cycles are being applied, which accounts in a total for 16 visits to the study site. Of course, patients also need stent placements. They have a stenosis, a tumor stenosis, and these stents must be replaced when needed or as planned. The PCI treatment is at the beginning of the study and towards the end, so after 6 months, 6 to 8 months. The laser treatment, it's actually a standard laser we are using. This is needed to activate the amphinex to help to destroy the tumor stenosis. And the idea is when we can manage the tumor stenosis pretty well, the patient outcome is much better than just with stenting. And we might also see an off-target effect of this kind of procedure, which might be an immunological induced effect. Move on, please. And that's actually the major risk of not only the study, but of having a biliary cholangiocarcinoma. It's cholangitis and infections. That's in my experience, and not only in my experience in the literature, and also with my colleagues, that's the most frequent cause of death in patients with a Klatskin type tumor with a perihilar cholangiocarcinoma. So this must be really carefully managed, and biliary drainage by stenting is the standard of care procedure. And we hope that with the PCI treatment, we might prolong actually the intervals also of stent replacement. We mentioned already at the beginning, or I mentioned it, that with the treatment, with the photodynamic PCI/PCI treatment, there are typical risks. And one risk is that a patient becomes more sensitive to light after the amphinex is being injected. That's why we will instruct every patient very carefully about skin toxicity, and the patient has to wear special sunglasses, which will be provided by the sponsor, and also a lumimeter will be provided to measure the intensity of the light. And what is really important is to protect the skin and the eyes if a patient goes outside in the bright daylight for the first days, maybe the first 2 weeks. Thereafter, the patient is not as sensitive to light as just at the beginning, and this will go away, actually, the light sensitivity. And it's also important to go out again and to get used to light again. But it's a matter of time, actually. It's just at the beginning, after the injection of the substance. And honestly, also with photodynamic treatment, which is also used in Europe at some places, it's the same. It's the same kind of light sensitivity. So this is related to the kind of photodynamic procedure and amphinex procedure. And of course, in every patient receiving chemotherapy, there are some special risks, which are actually the standard risks, either inside or outside a clinical trial. Next slide, please. If you want more information on this trial, you can find the information, of course, on the clinicaltrials.gov webpage. And also, of course, at participating US sites, which are the ones showing this slide here. It's the City of Hope National Medical Center in California. It's Emory at Atlanta. It's the University of Chicago in Chicago, the University of Louisville in Kentucky, and it's the Mayo Clinic in Rochester and the Baylor College of Medicine in Houston. These are the sites, and if a patient is interested, please seek advice at these sites. And of course, every patient must be screened if he fits the inclusion and does not meet an exclusion criteria, as always in a clinical trial. Move on. Do we have another slide? This is it, actually. This was my presentation on the release trial, and I'm open to your questions.
Okay, so I see we have some questions submitted, and we also had some questions pre-submitted. So I'm going to ask a few of the ones that were pre-submitted. How does genetic or genomic profiling play into this trial?
Sorry, can you repeat?
Yes, how does genetic or genomic profiling fit into this trial?
It's not a biomarker-driven trial. It's based on a genetic background. It's for all comers. We do not test actually inside the trial patients for having a certain genomic profile. It's just a tumor location, which is important. It's perihilar and distal cholangiocarcinoma requiring stenting. But in those patients, who are candidates to participate, they must not be treated before with systemic treatment. That's important. Just a limited number is allowed.
Okay. And then are patients on the PCI protocol supplemented with vitamin D to counteract their inability to be exposed to sunlight?
Well, it's just a matter of a very short time. It's like a 2 to 3 week period of time. I think this does not make a difference to take vitamin D or not during such a short period of time. But if a patient wishes to get a prescription of vitamin D, it can be done. It's not part of the protocol.
Okay.
Just ask the doctor.
And then can patients from Russia participate in this clinical trial? Of course, if they come to a location that's available.
That's a question to the sponsor, actually. Usually, well, we in Germany, we require that the patient is a habitant of the country and has a permanent residency. I guess it's the same in the other countries.
Okay, so
we don't have answer now for this, and also we need to understand that the protocol requires rather many visits mostly because the infusion of the chemotherapy is the standard treatment is fairly demanding. Every 21 days, one need to be basically 2 or 3 times in a hospital. So traveling long distances is not considered easy in this kind of trial. And this comes on top to what Professor Troyan just said, that we can check it, but it's because the treatment itself is expensive and it's provided by the state or by the countries. It's difficult for me to see that a patient could come from other countries.
okay,
and where the
thank you.
trial is conducted. We can look at it if specifically through clinicaltrials.gov, once submit this question, we can look into this.
That sounds good. Okay, what is the nature of the skin and eye reaction to light following treatment? What symptoms should be anticipated?
It looks like sunburn. That's actually the short answer. So the skin gets more sensitive to light, and the reaction of light is a sunburn. So we had also experience with some patients not taking it too easy, actually, and going out too fast after the Amphenex injection. And this will cause definitely a sunburn in the first days. So that's really my advice to follow the protocol.
Okay. What are the criteria for a patient not located in one of the European locations to enter the trial? My husband is British, but I am Italian. Could he try to enter the trial in Italy?
Well, my personal view is if the patient has a residency, at least for the period of the trial in the country where the study site is, then it's feasible. But if he has to travel for every visit from abroad, for me, it doesn't make sense, actually. And we in Germany, we are strict. We are not allowed to do this.
Okay. Are patients with metal stents allowed, or is it only for plastic stents?
Amir, am I right? Only plastic,
Yeah.
right?
Only plastic. So we evaluated this really carefully about all the options that exist. There are metal stents that are covered and are not covered. And we looked into this very carefully, tried to expand. And we concluded after all the evaluations that only plastic stent is allowed during the treatment period.
But
so that it can be, that it can be removed before illumination and can put back to prevent adverse events related to the illumination.
Yeah, from a technical point, if it is a covered metal stand, it might be removed. If it is an uncovered stand, it's not possible to remove an uncovered stand which has been placed a couple of weeks before. So uncovered, no. Covered, yes, might be possible, but it must be taken out before the procedure.
Okay, thank you. Let's see, we had one submitted early. Are PTC patients eligible, and does PCI increase side effects of the Gemzar? And can this be used on metastasis? That was all one question.
One, okay, so PDT. PDT means percutaneous drainage of the biliary tract, for those who are not familiar with this. And this is, of course, also possible that it might not be feasible to place a stent because of, well, a certain anatomy, for example, operations before, which make it not possible to get access to the stenosis. And if the patient has a PDT, no problem. It can also be done with patients having a PDT.
Okay, and does PCI increase the side effects of the Gemzar, the gemcitabine?
This is the randomized trial. So the honest answer is we must show this, but my experience, my personal experience, and also from the other sides is no, it does not. It does not increase the toxicity of gemcitabine. Gemcitabine is very well tolerated in the majority of patients. Some patients get side effects like thrombopenia and neutropenia, but I haven't seen actually more side effects with gemcitabine actually during the
I agree with your Professor Troyan, and I can add to this that the fimaporfin, the drug of the trial by itself, is not interacting with gemcitabine. The only thing that we expect Amphinex to do is to enable gemcitabine to enter cells where there is illumination. And we do illuminate only in the lesion area. And most of the adverse events of gemcitabine, which are not so, by themselves are not so high load, they are systemic. But because there is no interaction between these two drugs, we don't expect at all that there is like increase of the gemcitabine safety profile, not at all.
Okay. And then can this be used on metastasis? But I think you referred to that in your presentation, that there maybe is like an abscopal effect or something.
Well, if a patient has intrahepatic or localized peritoneal metastasis, there was an amendment of the protocol, and correct me if I'm wrong, Amir, but these patients are also eligible. But if they have extrahepatic metastasis, no, it doesn't make sense.
So I guess the question was, if I understand correctly, is whether the treatment works on metastasis. Can this be used on metastasis? So illumination itself is done only in the bile duct. We do not aim to illuminate metastasis specifically other than the lesion that is in the bile duct. But like Professor Troyan has mentioned, there is, or we consider, we don't have strong evidence to say this, but we consider that there is potential that the activity, that the increased activity in the bile duct may increase the activity of the immune system towards other lesions in the body. So there is no direct effect of the treatment on metastatic disease, but we consider that there is potential benefit through the activity of the drug in the bile duct. If this is correct, Troyan, Professor Troyan, if you accept.
Yeah, I do.
Yeah.
Okay, and I think these last two questions are kind of similar. How will this treatment increase life expectancy? And then what is the extra survival rate from the trial? And I'm not sure what you can answer on that, but they're pretty similar questions.
Well, we have just run the phase 1. This is limited experience, and it was encouraging. It was the overall survival was, correct me if I'm wrong, Amir, 20+X months.
So it depends on the population that we look. I see that we had several cohorts with different dose levels. The results were better than what we see with the standard treatment of gemcitabine cisplatin, but we have to consider the small number of patients. So this is actually one of the biggest questions from the RELEASE study, and this is why we do this study, to answer this question, whether it improves survival of patients. The results, like has been said, are encouraging, but based on very small population, and we cannot generalize an answer based on these very few patients.
Okay.
So we cannot promise anything around this, but we hope it is.
Good, we do too. If anyone else has any more questions, please feel free to submit them in the chat. And I think we have some more polling questions to do, correct?
I'll launch it right now.
Okay. So the last two polling questions are, did you find this webinar helpful? Yes or no? And would you be interested in participating in this trial? Yes, no, or not applicable? We'll give you guys some time to finish that.
Let's do another 10 seconds. 5, 4, 3, 2, 1.
Yes, it was helpful. And so, yes, and some are not applicable, but no no's. So we'll have to get this webinar out there. And let me see, I think there might be a couple more questions. Thank yous, a bunch of thank yous for the presentation. And yes, this webinar is recorded and it will be available to rewatch. We'll have it on the website and on our YouTube channel, and we'll share it on social media. So we should have access to that shortly. Yep, I just got a lot of thank yous and very helpful information to the presenters. Anything else, presenters, that you would like to add before we close out?
Thank you, everybody, for getting us the space to really, well, show some data of this trial, and hopefully to encourage some patients to come to the study sites.
Thank you guys so much for the presentation and for the information. We appreciate it very much.
Thank you very much.
Everyone have a wonderful day and take care.
Thank you very much.
Bye-bye. Have a great day.
Bye.